Females have two fallopian tubes, also called uterine tubes, also called oviducts, that extend laterally from the uterus. They measure about 10 centimeters or 4 inches long, and they lie within the folds of the broad ligaments of the uterus. So here you can see the broad ligaments, okay, and the fallopian tubes are lying within that, sort of being held up by. So they provide a way for sperm cells to reach those oocytes that have been ovulated and are now out in those fallopian tubes. So it transports the secondary oocytes, and then if fertilization occurs, it transports that zygote and the developing embryo from the ovaries to the uterus. Now, obviously it's not an embryo yet, but the cells that are going to become the embryo are going to be transported through that fallopian tube to the uterus. So at each end of the fallopian tubes, you have these little finger-like extensions called fimbriae that lead to an expanded area called the infundibulum, and then the largest part, which makes up about 2/3 of the fallopian tube, is called the ampulla. Within the fallopian tubes, there are simple columnar epithelial cells that are ciliated, and it functions as sort of a conveyor belt to help move that fertilized ovum or the secondary oocyte, if fertilization doesn't occur, within the uterine tube toward the uterus. All right, so let's talk a little bit about the uterus, which is what we commonly call the womb. So it serves as the part of the pathway for sperm to be deposited, for sperm that is deposited into the vaginal canal to reach the uterine tubes. It's also the site for implantation of that fertilized ovum and the development of the fetus during pregnancy and labor. During the reproductive cycles, when implantation doesn't occur, the uterus is also the source of the menstrual flow. So the uterus is situated between the urinary bladder and the rectum, and it's about the size and shape of an upside-down pear. In women who have never been pregnant, it's only about 3 inches long and about 2 inches wide, and maybe an inch or so thick. The uterus is larger in females who have recently been pregnant and smaller or atrophied when sex hormone levels drop, such as when a woman enters menopause. The anatomical subdivisions of the uterus include the fundus, which is the upper portion, the body, which is the main part, and the cervix, which is the part that opens into the vaginal canal. So if you look at this model, this would be the fundus, this would be the body, and there is the cervix, which is the lower part. Or we can back up right here. There is the fundus, all of this is the body, and there is the cervix, and you can see that the cervix is actually sitting in the vaginal canal. The interior of the body of the uterus is called the uterine cavity, and the interior of the cervix is called the cervical canal. So the cervical canal opens into the uterine cavity and into the vagina at the other end. All right, so I wanted to tell you something else here. Oh, a disorder. A condition called uterine prolapse can occur when there's a weakening in the pelvic floor. So prolapse means to fall down or falling backwards. So this results from a weakening of the supporting ligaments in the pelvic musculature that happens normally in some women with age, but can also happen because of disease, or if there is a very traumatic, for instance, there's a large baby that is delivered vaginally, or chronic straining from coughing or difficult bowel movements where you're pushing down very hard in that Valsalva maneuver that we've talked about before. This can also happen as a result, though, of pelvic tumors. So the prolapse can be characterized as first degree, which is mild, where the cervix remains in the vagina. Second degree is when the cervix protrudes through the vagina to the exterior, and third degree is complete, where the entire uterus is outside the vagina. You may also sometimes see this classified even further to fourth degree, where the urinary bladder starts to prolapse as well. But depending on the degree of the prolapse, treatment may involve just simply doing pelvic exercises such as the Kegels, where you tighten your pelvic floor muscles to strengthen those muscles that hold the uterus in place. Dieting, if the patient's overweight. A stool softener can be used to minimize the straining and the pushing that would accompany defecation during constipation. Or there is therapy where a little rubber device is placed around the cervix that helps to sort of prop the uterus up, or surgery can be done to tack the uterus back in place. So when you look histologically at the uterus, you'll see there are three very distinct layers of tissue: the perimetrium, the myometrium, and the endometrium. Now, think back to your terminology. You know what peri means, right? Peri means around. So the outer layer is the perimetrium, and it's also just simply the serosa, or the visceral peritoneum, that lies on the surface of the uterus. So metri refers to uterus. It's composed of simple squamous epithelial cells and areolar connective tissue. Myo, you know, means muscle. So the middle layer of the uterus is the myomuscle, and it's made up of 3 layers of smooth muscle fibers that are thickest at the fundus and thinnest in the cervical area. The thick middle layer is circular, and the inner and outer layers are longitudinal or oblique. So during childbirth and labor, these different orientations of the muscle fibers give these coordinated contractions of the myometrium, and helps to expel that fetus from the uterus. And of course, it's also in the myometrium that we have a large number of receptors for what hormone? That's right, oxytocin. All right, so the inner layer, you would have known inner because you know that endo means inside, right? So the inner layer is the endometrium, and it is very highly vascularized. The endometrium itself is divided into 2 layers: the stratum functionalis, which is the functional layer that lines the uterine cavity, and it's what is sloughed off each month during the menstruation. The deepest layer, the stratum basalis, basal layer, is a permanent layer, and of course it's the one that gives rise to the new stratum functionalis each month after menstruation has occurred. So the uterus is also very extensively vascularized because, one, if fertilization does occur, then we've got to develop and create a placenta, and have blood supply for nutrients to come into that placenta, and also, of course, to make sure that there are sufficient nutrients for that developing embryo in the tissue until the placenta has fully developed. But because that stratum functionalis has to regrow every month after menstruation, this very rich blood supply ensures that there are nutrients and oxygen and all the things needed to supply and regrow new tissue. The cervix of the, I'm sorry, I just completely started looking at the image there and lost my train of thought. So there are secretory cells of the cervix that secrete a very thick cervical mucus, which is a mixture of glycoproteins and lipids and water, and lots of enzymes as well. So the cervical mucus is forming sort of a plug or a block to keep things from getting into the cervix until it's time for something to get in, right? So when do we want sperm cells to be able to get through the cervix and into the uterus? Well, obviously, when there's an oocyte out there in the fallopian tubes, right? So the cervical mucus is more hospitable to sperm at or near the time of ovulation, because when the estrogen levels are high that accompanies ovulation, then that mucus becomes less viscous, so it thins out and becomes more alkaline. At other times, though, it's very, very thick, and it forms that plug. Cervical mucus supplements the energy that's needed, because remember I said it's rich in glycoproteins and lots and lots of lipids, so lots of nutrients there to use as an energy source. The cervical mucus also may play a role in capacitation of the sperm cells. Remember, we talked about this when we did the male reproductive system. So that was that series of changes that sperm cells have to undergo once they're in the female reproductive tract before they're capable of fertilizing an egg, right? So capacitation causes the sperm cell's tail to beat even more fast and hard, and it prepares the sperm cell's cell membrane to fuse with the oocyte's cell membrane. So let's talk just a little bit here, since we're talking about the uterus, about the hysterectomy, which is a surgical removal of the uterus. And this is the most common gynecological operation. It's usually done in conditions, because of conditions such as fibroids, which are non-cancerous tumors that are made up of a lot of muscle and fibrous tissue. It could be because of endometriosis or pelvic inflammatory disease. It could be that there are recurrent ovarian and uterine cysts, excessive uterine bleeding, and obviously if there's cancer of the cervix, the uterus, or the ovaries. In a partial hysterectomy, the body of the uterus is removed, but the cervix is left in place. In a complete hysterectomy, the removal of the body and the cervix is done. In a radical hysterectomy, the removal of the body and the cervix of the uterus, and there's the removal of the uterine tubes and possibly even the ovaries. Some of the pelvic lymph nodes and supporting structures such as the ligaments may be removed, and in some cases even the superior portion of the vagina. This is usually done if there is cancerous tissue found in that area, so that you are sure to remove all of the tissue to where the cancer may have reached. So a hysterectomy, though, can be performed either through an incision in the abdominal wall or through the vaginal canal, depending on what the reason for removing all of that tissue is. The vagina is a long fibromuscular canal lined with a mucous membrane that extends from the body of the uterine cervix, so it's one continuous mucous membrane. It's the receptacle for the penis during sexual intercourse, the outlet for the menstrual flow, and, as we've mentioned, the passageway for childbirth. At the superior end of the vaginal canal, there's a recessed area, you can see right here, called the fornix, and I sometimes call it the dead end, where some of the sperm cells get trapped when I'm teaching this in lab. But it surrounds the vaginal attachment to the cervix. This is also an area where if you use a contraceptive device known as a diaphragm, you actually fit that diaphragm into the fornices here around the cervix, and that sort of suctions it and holds it into place to cover the cervix so sperm cells can't get through. Histologically, the vagina consists of non-keratinized, squamous, stratified epithelial cells. Do you remember your terminology? Non-keratinized, so it doesn't contain the waterproof protein. Stratified, many layers. Squamous, flat. So this type of epithelial tissue, but also some areolar connective tissues, and these lie in a series of folds called rugae. So you can see how the vaginal canal appears to have ridges. Those are the folds called rugae. What else do we want to talk about here? Let's go ahead and move. So, whoops, there we go. I've already taken you through that. So the muscular layer is composed of an inner circular layer and an outer longitudinal layer of smooth muscle that has the ability to stretch during sexual intercourse and to stretch, of course, during childbirth as well. There's a thin fold of vascularized mucous membrane that's called the hymen that forms a border around and partially closes the inferior end of the vaginal opening to the exterior, and that's what we call that opening is the vaginal orifice. After its rupture, usually following the first sexual intercourse, only remnants of the hymen remain. Sometimes the hymen completely covers the vaginal orifice in a condition called imperforate hymen, where surgery is needed to open that orifice, because as long as there is a closure there, of course, the menstrual flow has no way to escape. All right, so before we begin here, I want to mention a term called episiotomy. So an episiotomy is when a surgical incision is made between the vaginal orifice and the anus. Usually, of course, not all the way through, but what it does is to open the area, the vaginal opening, so that a larger baby can be passed through. Or if there is a breech presentation, such as if the buttocks or the lower limbs are coming out first, or if there's fetal distress, so there's an abnormal heart rate and forceps need to be used to deliver that baby. or if there's a very short perineum that allows for very little stretching of the vaginal orifice. So the episiotomy is a surgical incision that's done and then, of course, stitched back up, and those sutures are usually absorbed within a few weeks. This usually allows for much better healing than allowing that tissue to tear during childbirth. All right, so the vulva or pudendum refers to the external genitalia of the female. So anterior to the vagina and the urethral openings, okay, so here we have the vaginal orifice, there's the urethral orifice. So anterior to that, we have the mons pubis. So the mons pubis is an elevation of adipose tissue covered by skin, and once the female reaches puberty, of course, the pubic hair, and that provides a cushion over that pubic symphysis and the pubic bones, which we know are located right here. From the mons pubis, there are two longitudinal folds of skin. So we have the labia majora, that literally translates to mean large lips, and the labia minora, which are the small lips. So the labia majora are also going to be covered with pubic hair, and they contain a lot of adipose tissue, sebaceous glands, and apocrine sudoriferous glands. They're homologous to the scrotum. Let me back up. Do you remember what apocrine glands are? Those are the sweat glands that produce stinky sweat. Medial to the labia majora are two smaller folds of skin called the labia minora. Okay, so here you can see smaller labia minora. Okay, so the labia minora don't have the pubic hair. They don't have fat. They have very few sudoriferous glands, but they do contain sebaceous glands, which produce antimicrobial substances and also provide a little bit of lubrication during sexual intercourse. Okay, here we have the clitoris, which is a small mass that's composed of two columns of erectile tissue, the corpora cavernosa. Where have you heard that before? That's right, those were the two of the major columns of erectile tissue, the two larger ones in the penis. So same tissue, but there's also numerous nerves and blood vessels. So the clitoris is located at the anterior junction where the labia minora come together. There's a layer of skin called the prepuce of the clitoris. Where have you heard prepuce? That's right, that's the foreskin over the penis, the glans penis, right? So there's a prepuce, a covering of skin, over the body of the clitoris as well. The clitoris is homologous to the glans penis in the male. Like the male structure, like the glans penis, the clitoris is capable of enlargement with tactile stimulation and has a major role in the excitement and orgasm in the female. The region between the labia minora is called the vestibule. So within the vestibule is where you find the hymen, if it's still present, the vaginal orifice, the external urethral orifice, and the opening of these small little ducts that are called vestibular glands. On each side of the vaginal orifice are the greater vestibular glands, sometimes called Bartholin's glands, and these open through ducts into a small groove between the hymen and the labia minora. They produce a small amount of mucus during sexual arousal and intercourse that adds to the cervical mucus and provides lubrication. The greater vestibular glands are homologous to the bulbourethral glands that we talked about in the male. The bulb of the vestibule consists of two elongated masses of erectile tissue that are just deep to the labia on each side of the vaginal orifice. And the bulb of the vestibule becomes engorged, it's erectile tissue, so it becomes engorged with blood during sexual intercourse, and that narrows the vaginal orifice and places additional pressure on the penis during sexual intercourse. So the bulb of the vestibule is analogous or homologous to the columns of erectile tissue in the male. All right, so in this image you can see the perineum, which is the diamond-shaped area that's medial to the thighs and buttocks in both males and females. So it contains the external genitalia and the anus. The perineum is bounded anteriorly by the pubic symphysis and laterally by the ischial tuberosities. I'm taking you back into all that bone stuff you had to learn, right? Okay, so there's your pubic symphysis, there are your ischial tuberosities, and the boundary posterior is the coccyx. So if you draw a transverse line between the ischial tuberosities, okay, right here, that divides the perineum into two urogenital triangles, or into an anterior urogenital triangle where the genitalia are located, and an anal triangle that is located here where the anus is. All right, and now let's talk about the mammary glands, because remember, the mammary glands are a part of both the integumentary system and the reproductive system. So each breast has one pigmented projection called the nipple that has a series of really closely spaced openings of ducts that are called lactiferous ducts, and that's where the milk is going to come out. The circular pigmented area around the breast is called the areola, and it has a rough-looking appearance because it contains some modified sebaceous glands. So within each breast is a mammary gland, which is a modified sudoriferous gland that produces milk. Mammary glands consist of about 15 to 20 lobes or compartments. I'm going to go ahead and move to the picture so you can see this better. So there are about 15 to 20 lobes within the mammary glands, and each of these is separated by variable amounts of adipose tissue. So in each lobe there are even smaller compartments called lobules that look like little clusters of grapes. So these are clusters of milk secreting glands that are called alveoli, and these are embedded in some of the surrounding connective tissues. So the alveoli are surrounded by myoepithelial cells. Now think a moment about what that's telling you. Myoepithelial. Myo always means muscle, and epithelial. So epithelial is the glandular part, myo is the muscular part. So when milk is being produced and it's stimulated by oxytocin, the breasts are stimulated by oxytocin to let that milk down when a baby is nursing, then those myoepithelial cells are going to squeeze those little alveoli, and that helps to propel the milk toward the nipple. So when milk is being produced, it passes from the alveoli into a series of tubes into the mammary ducts. Near the nipple, the mammary ducts expand a little bit and form sinuses called lactiferous sinuses, and there's a little bit of milk that can be stored in those lactiferous sinuses before draining into the lactiferous ducts. The functions of the mammary glands should be pretty obvious: to make, secrete, and eject milk. These functions collectively are called lactation, and of course they're associated with pregnancy and childbirth. So milk production is stimulated, as you know, by the hormone prolactin from the anterior pituitary, and of course working synergistically with that prolactin is the progesterone and the estrogens. The ejection of milk is stimulated by oxytocin. Again, remember we talked about this with the endocrine system, and that oxytocin is going to be released from the posterior pituitary in response to sucking, for the infant sucking on the mother's nipple, which is an action we call suckling. So let's talk just briefly now about a couple of clinical issues related with the breast. So breast augmentation is when you have a surgical procedure to increase the size and the shape of the breast. So this can be done for many different reasons: to enhance the size of the breast for women that feel their breasts are too small, to restore breast volume after weight loss or following pregnancy, to improve the shape of the breasts that are sagging, or improve the appearance because of surgery or trauma or congenital abnormalities or reconstructive surgery after a mastectomy because of breast cancer. But regardless what the reason, the procedure is the same. So most commonly the implants are filled with either a saline solution or a silicone gel, and there's an incision made under the breast or around the areola, sometimes even in the armpit, and a pocket is made to place the implant either directly behind the breast tissue or underneath the pectoralis major muscle. Breast reduction is just the opposite, so it's removing breast tissue, decreasing breast size by removing fat, skin, and glandular tissue. This is commonly done because of chronic back, neck, or shoulder pain that can lead to poor posture. Also, it can lead to circulation or breathing problems. I'm sorry, my tongue is just getting tangled up. Should be telling me it's time to stop this video, right? We're almost there, I promise. Sometimes with very large breast, a rash can develop under the breast, and it can cause you to have restricted levels of activity, sleep problems. Deep grooves can be created in the shoulders from the pressure on the bra straps, and it can just simply be difficult fitting into bras and clothing. The most common procedure involves an incision around the areola, down the breast toward the crease between the breast and the abdomen, and then along the crease. The surgeon removes excess tissue through the incision. In most cases, the nipple and the areola remain attached. However, if the breasts are extremely large, the nipple and the areola may have to be removed and then reattached at a higher position once the excess tissue has been removed. And then finally, we'll talk just briefly about fibrocystic disease of the breast. So the female breasts are very highly susceptible to cysts and to tumors, and we'll talk about breast cancer near the end of the reproductive system. Fibrocystic disease is the most common cause of breast lumps in female, where one or more cysts, or just fluid-filled sacs and thickenings of the alveoli, develop. So this condition, which occurs mainly in females between the age of 30 and 50, is probably due to an excessive amount of estrogens or a deficient amount of progesterone after ovulation during the luteal phase of the reproductive cycle. And of course, we're going to get to all of that in just a few minutes. The fibrocystic disease usually causes one or more breasts to become lumpy, swollen, and very tender for a week or so before menstruation occurs. Now, I am certainly not a doctor, but I have heard it said that most of the time in the early stages of breast cancer, you may feel a lump, but the lump is not painful. If it is a very painful, tender lump, most of the time it is fibrocystic disease. Now again, I am not diagnosing you, nor do I hope that you use this information to diagnose anyone. I am simply telling you something that I have heard. I have had fibrocystic breast disease, and I know that the fibrocystic lumps are very tender.